You. Good morning, everybody. Welcome to Pediatric Grand Rounds. Today, our speaker is Dr. Sarah Coggins, and she's going to be presenting virtually from Pennsylvania. Uh, Dr. Coggins is an instructor of pediatrics at the University of Pennsylvania and an attending neonatologist in the Division of Neonatology at Children's Hospital of Philadelphia and CHOP Newborn Care at Pennsylvania Hospital. She completed her undergraduate and medical school training at Vanderbilt and subsequently completed her pediatric residency and her neonatal perinatal fellowship at the Children's Hospital of Philadelphia. Her research interests include neonatal infectious diseases and optimal use of antimicrobial therapy in infants at risk of infection. She has conducted research focused on improving neonatal sepsis recognition and diagnosis, as well as characterizing severe outcomes of infants with neonatal sepsis. Her current research focuses on approaches to risk stratification of preterm infants at risk for early onset sepsis and the use of pharmacokinetic methods for optimizing neonatal antibiotic prescription. Please join me in welcoming Dr. Sarah Coggins.
Thank you so much for having me. I'm thrilled to be able to join you guys virtually. It's nice to meet you all. As mentioned, I'm going to talk today about neonatal antimicrobial pharmacology and talk about some of the barriers and opportunities that we have to improving drug dosing for our smallest babies. I have no conflicts of interest or financial disclosures. And the objectives of my talk today are first to remind us all of the principles of clinical pharmacology as applicable to neonates, which are a special population in pharmacology. Secondly, to understand differing pharmacokinetic and pharmacodynamic profiles of commonly used antibiotics in the NICU. And finally, to understand barriers to optimizing neonatal pharmacotherapy and potential strategies to overcoming them. So neonatal antibiotic exposures are really common. Up to 45% of all infants who are admitted to a NICU in the United States are administered at least one parenteral antibiotic during their hospitalization. And as you might imagine, preterm infants are disproportionately antibiotic exposed compared to term infants related to critical illness, need for intensive care, supports, and related to that, just long NICU hospitalizations that intrinsically put them at risk for hospital-acquired infections. To put this into a bit of perspective, this was a retrospective study from an administrative database that looked at antibiotic exposures within the first 3 days of life at over 300 NICUs in the United States. And what the study found was that approximately 79% of all very low birth weight infants, or VLBWs, born less than 1,500 grams, were exposed to antibiotics in the first 3 days after birth. Up to 87% of ELBWs, or extremely low birth weight infants born less than 1,000 grams, were administered antibiotics in the first 3 days after birth. So at that time, which was 2009 to 2015, there was almost ubiquitous empiric antibiotic administration among the smallest babies. There was also significant center variation in prescribing. As you can see from these figures, the proportion of VLBW and ELBW babies who were administered empiric antibiotics ranged from 25% to 100%, depending on the center. So you may ask, where does all of this heterogeneity come from, and why is this occurring? There's also substantial heterogeneity in just what antibiotic dosing is administered to these babies, which has been identified in observational studies. There was one study of over 2,000 neonatal meropenem courses administered in the United States. And these authors found that only 32% of these courses were appropriately dosed based on available pharmacokinetic data. And in most cases, these courses were underdosed. A second point prevalence study of 89 NICUs in 21 European countries found that penicillin was generally overdosed and that vancomycin was underdosed according to British National Formulary for Children guidance. And this was particularly common among preterm infants. Now, this is not limited to Europe, or, we have varying guidance even in the United States among very common and prominent dosing references used in daily clinical practice. Here I'm going to just compare as a thought experiment gentamicin dosing guidance from 3 references that I'm sure many of you use daily, which include the FDA label, the AAP's Red Book, antibiotic dosing guidelines, and finally the NeoFAX formulary, which is a common proprietary formulary used particularly in neonatal care. So the first thing you'll notice here is that even the framework for how to separate dosing, like babies into buckets for dosing, differs. The FDA label makes no distinction for gestational age and just says, if you're greater than 7 days, you give them this. If you're less than 7 days, you give them this. The AAP Red Book makes such determinations by gestational age, less than 29 weeks, 30 to 34 weeks, and greater than 35 weeks. And then the NeoFAX formulary bases its dosing guidance not on gestational age, but on postmenstrual age. So from the get-go, we're not even comparing apples to apples when we compare these formularies. When you then look at within the major buckets how dosing guidance is subsequently tailored, this also differs. The AAP Red Book, for example, among infants less than 29 weeks, further tailors its guidance to postnatal age less than 14 days and greater than 14 days, while the NeoFAX formulary at less than 29 weeks postmenstrual age has buckets that are defined by less than 7 days, 8 to 28, and greater than 29 days. So clearly these guidances are not aligned. And as a thought experiment, to say that I have a 10-day-old baby who's born at 26 and 0 weeks gestation, who I am deciding to administer gentamicin to, say for a late onset sepsis evaluation. Let's look at what the recommendations would be for me as a clinician if I were to administer antibiotics to this baby. So the FDA label would suggest that for this baby, I would administer 2.5 milligrams per kilo every 8 hours. In contrast, the Red Book would recommend that I would give this baby 5 milligrams per kilo every 48 hours. And the NeoFAX formulary would tell me to give 4 milligrams per kilo every 36 hours, which is clear as mud, right? So you, like me, may be asking, why does all of this variation exist? And isn't this really confusing for clinicians? And the answer is yes, it is confusing for clinicians. And as to why this variation exists, I think there's a lot of reasons. First of all, it may just be that as this data becomes more and more common, there may be general lack of awareness of new data as it comes out. I also think that from sort of a regulatory and oversight standpoint, individual clinicians and hospitals may be reluctant to implement new dosing guidelines in the absence of true efficacy targets, meaning does this antibiotic dose prevent disease or prevent death? As most of the studies that we have really just relate antibiotic dosing to a particular therapeutic target. Say, did we reach X concentration? Not so much, did we prevent the baby from getting sick? And finally, and probably most importantly, traditional dose comparison studies, like would be done in an adult population via a randomized control trial, are difficult to perform and really just not feasible to do in neonatal populations. So the questions that will guide sort of the rest of this talk are first, where do these antibiotic dosing recommendations come from? In particular, how are these doses developed and optimized for neonates? And how can we optimize antibiotic dosing to achieve this efficacy that we're looking for while limiting excessive dosing and toxicity? And so that's where the science of clinical pharmacology comes in. I'm sure many of you remember learning about this ad nauseum in medical school, so we're going to give a little bit of a refresher. This is a science that is concerned with the interaction of drugs with cells, tissues, and organisms. And its most important principles include pharmacokinetics and pharmacodynamics, which we are going to review in a bit of detail. So pharmacokinetics is defined as the relationship between the drug dose and subsequent concentrations in blood over time. And more simply stated, this is the body's effect on the drug. Whereas pharmacodynamics is defined as the relationship between the drug concentration in blood and its effect in the body. Now, for antibiotics, this could mean a subtherapeutic concentration that doesn't kill the bacteria, a therapeutic concentration that kills the bacteria, or a super therapeutic concentration that causes toxicity. More simply stated, pharmacodynamics is defined as the drug's effect on the body. Now, pharmacokinetics traditionally is composed of 4 primary components, which are absorption, distribution, metabolism, and elimination. And as you might expect, unique neonatal physiology affects each parameter, and we're gonna talk about each of those. Now, absorption describes drug transit from the site of administration to the systemic circulation. And this is a major determinant of drug bioavailability, where bioavailability refers to the proportion of drug that is available for use by the body. You may remember that IV administration correlates to 100% bioavailability, which is why in practice many of our neonates are administered IV antibiotics to obviate some of the concerns about absorption in this population. Now, there are a number of neonatal considerations when it comes to absorption, and primarily this is related to oral administration of drugs. So we know that neonatal gastric pH at birth is neutral, and there's delays in acidification over the first several weeks of life and really doesn't reach adult levels until the baby is several months to a year of age, which obviously impacts oral drug biotransformation when it hits the stomach. Similarly, there are slower rates of gastric emptying, particularly in preterm infants, and intestinal motility in preterm infants, which generally just, delays the time that drugs transit through the gastrointestinal tract and further delays absorption. There's also differences in sort of, what kind of, food the baby is getting with the drug that impacts absorption. So we know that, breast milk is faster absorbed than formula. We know that preterm infants have slower absorption than term infants. And finally, which is relevant to not just neonates, but probably older kids as well, is that we know that absorption can be altered by the route of administration, particularly if it's given through an NG tube or an OG tube, as many lipophilic drugs can adhere to feeding tubes and reduce drug delivery for that reason, which is a very relevant concern in NICUs where, for most kids under 34 weeks, their oral drugs are being administered via an NG tube. Now, distribution is a somewhat complicated concept, but I'm going to ideally hope to present this in a way that is accessible to everyone. Now, this is the process by which, once drugs are administered, by which they move from the intravascular space to the extravascular tissues. And the primary parameter that we use to describe this is volume of distribution, which I'm going to shorten as VD through here, which is a parameter that really relates the total amount of drug in the body to the plasma drug concentration. Now, this figure on the right I really like with these mice, because I think it does a good job of sort of comparing lower volume of distribution to higher volume of distribution. Now, if you look at the mouse on the left, you can see that this mouse on the left, he's supposed to represent lower volume of distribution, because the drug, as you see, these little blue dots, preferentially lives in the intravascular space, in the bloodstream, and less of it gets out to the tissues. For that reason, because the drug primarily stays in the intravascular space, you need a lower dose to achieve a goal concentration, because most of that drug is going to stay in the bloodstream. In comparison, the mouse on the right has a higher volume of distribution. And in this case, the drug will preferentially leave the intravascular space and go to the tissues. And so what that means practically, because the drug is leaving the intravascular space, you're going to need a higher concentration of the drug to achieve the same concentration that the lower volume of distribution mouse is seeing. Now, how does this impact neonates? Well, it turns out in a lot of ways. We know that neonates have significantly higher total body water content than older children and adults. Preterm infants, the total body water proportion is somewhere between 80 to 90%. In a term infant, somewhere around 75%. And by the time you get to a 1-year-old child, it's about 60% total body water content. as a corollary, neonates also have lower body fat content to make up for the fact that they're mostly proportionally water. And similarly, neonates have lower level of plasma proteins, which leads to lower levels of drug binding, meaning that higher amounts of free unbound drug are floating around. So what does that all mean put together? In sum, neonates have higher volume of distribution, meaning that because their total body water proportion is higher, most of the drug is going to leave the intravascular space and go to the tissues. And therefore, they're going to have lower peak concentrations for a given dose. This also means that if I gave the same weight-based dose to a preterm infant versus a term infant, the preterm infant is going to have a lower serum concentration because of their higher volume of distribution. The other thing that affects distribution is that volume of distribution is not necessarily a static concept. The volume of distribution can increase in the setting of inflammation or critical illness. So clinically, how we see this is, say, a baby who has sepsis, who has got capillary leak syndrome, that's going to increase their volume of distribution. A preterm baby with a big hemodynamically significant patent ductus arteriosus is going to have a larger volume of distribution. And, babies who have cardiorespiratory failure who are on ECMO and connected to an ECMO circuit with lots of tubing, they're going to have higher volume of distribution. So moving next to metabolism, which is the next step in this pharmacokinetic journey that we're on. We know that metabolism in neonates is mostly mediated by hepatic enzymes. In the phase 1 and phase 2 metabolism that occurs in the liver, its primary goal is to really biotransform drugs to make them increasingly water soluble to facilitate ultimate excretion. Now, the phase 1 metabolic reactions include things like oxidation, reduction, and hydrolysis. And these reactions are primarily governed by the CYP family enzymes. Now, as with everything that I've said so far in neonates, CYP family activity is variable at birth and is generally well below adult levels. If you look at the figure on the right, this is from a study that measured CYP enzyme activity over time. And you can see that in a fetus on the far left, enzyme activity is almost zero. It rises in a variable fashion depending on the CYP enzyme over time until it eventually achieves adult levels. We know that this is particularly relevant for drugs that are metabolized by CYP family enzymes, such as phenobarbital and midazolam, which may lead to higher concentrations in neonates due to delayed metabolism by these CYP enzymes that are just generally at lower levels in neonates. Now, when we look at the phase 2 reactions, these include sort of higher level, more complicated metabolic reactions. These are things like glucuronidation, methylation, and glycosylation, things like that. Now, a pertinent example is glucuronidation. We know that the enzymes that mediate glucuronidation, these UDP, glucuronyl transferases, perform at about 65% of adult activity levels, which leads to a pertinent example that I think probably all of us learned about in our time in board exams or pediatric residency, which is this gray baby syndrome that's related to the drug chloramphenicol. And this all relates to the fact that chloramphenicol is metabolized by glucuronidation, and unfortunately, when infants were administered or otherwise thought to be appropriate doses, because this enzyme metabolism was delayed due to low levels, the chloramphenicol doses reached toxic levels due to delayed metabolism, leading to this sort of bluish skin discoloration and ultimate cardiovascular collapse that was then called this gray baby syndrome. And it's a primary reason why chloramphenicol is not used anymore in neonates, due to this recognized severe toxicity risk related to delayed metabolism. And finally, we get to elimination. And we know that renal excretion is the most important route of drug elimination in neonates. And we know that this is mediated through a variety of mechanisms. There's tubular reabsorption, there's tubular secretion, and then there's glomerular filtration. But what's also very relevant, particularly in the neonatal population, is the fact that nephrogenesis is not complete until at least 36 weeks gestation. The figure on the left is a nice figure that sort of plots out expected GFR trajectories by postmenstrual age, ranging from 26 to 38 weeks. And this study looked at glomerular filtration rates from over 200 individuals, ranging from preterm infants to adults, and plotted out expected GFR trajectories, with the median GFR in this bold line in the middle, and then the 10th and 90th percentiles on either bounds. And what you see is that postmenstrual age generally rises with the GFR generally rises with postmenstrual age, which makes sense given what we know about developmental nephrogenesis. Relevant to preterm infants, we know that GFR rises with increasing gestational age and with rising postnatal age in the first month after birth. And in term infants, we know that these babies achieve about 50% of adult GFR at about 40 weeks postmenstrual age, and about 90% of adult GFR by a year of age. So clearly, these babies are at risk for delayed drug excretion related to immature renal physiology. Now, the most important parameters that define elimination are clearance and half-life, which are very much related concepts. Clearance is defined as the blood volume from which all drug is removed per unit time. A common sort of surrogate marker for clearance is creatinine, which is a common but imperfect marker of neonatal renal function. We know that creatinine is not always accurate in the first week after birth, as this can reflect maternal levels. And we also know that creatinine is just generally not a perfect marker of renal function, as it is both it is secreted and reabsorbed by the tubules. But in the process of pharmacokinetic studies over time, we also know that body weight, gestational age, postnatal age, and postmenstrual age also all contribute to renal elimination, which is why most of our modeling studies don't use creatinine alone as a marker of renal function, and really incorporates these other sort of physiologic parameters, given that we know that as a population, these affect elimination over time rather than one single physiologic marker like creatinine. And then half-life is defined as the time needed to clear half the drug from plasma. So we know that half-life is higher in neonates, related to their generally delayed clearance due to delayed renal elimination. And because we know that it takes about 3 to 5 half-lives to achieve steady state, that it takes longer to achieve steady state in neonates, which is important to keep in mind when we're starting a baby on a drug that we want to, achieve a certain serum concentration to achieve efficacy. So putting this all kind of into perspective and to put it all together, what are the primary PK considerations when we're thinking about preterm infants? As we mentioned, higher total body water content leads to higher volume of distribution and a lower plasma concentration for the same weight-based dose compared to a term baby. We know that immature enzymatic pathways delay drug metabolism, and we know that these babies have reduced GFR and delayed clearance. And so now we're going to talk about pharmacodynamics, which, as a reminder, is sort of what the drug does to the body. Like, what is the bang that we get for our buck in giving the baby this drug? For antibiotics, pharmacodynamics generally describes drug concentration effects relative to antibacterial target thresholds for individual pathogens. And the primary target threshold that's used for antibiotics is the minimal inhibitory concentration. The MIC is essentially defined as the lowest concentration of a drug that causes antibacterial killing. And I've tried to represent this in a pictorial way on the right, because I think this can be a challenging concept. But basically, this figure represents a common method of MIC determination called broth dilution, where a slurry of bacteria are exposed to increasing concentrations of antibiotic and then plated. And the lowest concentration that leads to bacterial killing is defined as the MIC. So here you see that you have bacterial growth with antibiotic at 1 and 2 mg per ml, but by the time you get to 4 mg per ml, there is no bacterial growth on the petri dish. So for this antibiotic, for this particular organism, the MIC would be 4 mg per ml. And related to this, There are varied PD parameters even among antibiotics to estimate antibiotic exposure relative to MIC. And we're going to go through these for the most common antibiotics that neonates are exposed to. So the first PD category are drugs that perform time-dependent killing. Now, these antibiotics have their highest efficacy as the duration of drug concentration above MIC increases. And I'm going to use this figure multiple times to illustrate this concept. So this is a concentration time curve where you see drug concentration sort of hit a peak and then fall over time. Now, shadowed in blue here is the duration of time where the drug is above MIC, which is this dotted line here. And the sort of PD metric that we use to equate this is the percentage of time where the drug is above MIC. So if I had to guess here on this concentration time curve, this drug percent T over MIC shadowed in blue is somewhere around 40%. Now, what's important to realize here is that once you achieve MIC, you don't get any additional efficacy for giving a higher dose of drug. It really only matters how long the concentration is above MIC, not so much the peak concentration. And this PD parameter is really most relevant to beta-lactam drugs, so penicillin, ampicillin, etc. Now, to view this in a different way, you can see on this figure on the right how optimizing drug delivery might optimize your percentage of time above MIC, which is our efficacy parameter. So you can do various things to improve this percentage of time above MIC. You can increase the duration of drug infusion, and you can also decrease the dosing interval. And so, for example, intermittent dosing. Say that we're giving ampicillin, and we're going to give it intermittently, and we're going to run it over 30 minutes. In this figure, with this intermittent dosing, in the percentage of time above MIC shadowed in orange here, you're going to achieve about 50% time above MIC. But say we wanted to extend that infusion time a bit to try and increase our time above MIC. And say we ran it over an hour. Here, you're going to get a higher proportion of time above MIC. And you're going to get about 75% time above MIC. And if we really wanted to optimize the period of time that the baby sees this drug efficacy, we could run the infusion continuously. And in this thought experiment, continuous infusion leads to 100% of the dosing interval being above MIC. Now, this is not necessarily something that is done in neonates, but continuous drug infusions are certainly evaluated for use in older kids and adults. I mean, I think there were papers in JAMA or the New England Journal in the last few months looking at continuous beta-lactam infusions to look at impacts on sepsis, which in adults seem to be less obvious than the pharmacokinetics would suggest. And again, classically, this time-dependent killing is relevant to beta-lactam drugs. Now, in contrast, concentration-dependent killing is very different than time-dependent killing. Here, we do care about the peak drug concentration. And these antibiotics demonstrate increased antibacterial activity and increased bacterial killing as drug concentrations increase. These drugs can also demonstrate a post-antibiotic effect, or PAE, where essentially they can still demonstrate bacterial killing even when the drug concentration falls below MIC. Now, on the figure on the left, you can see that the parameters that we care about in these concentration-dependent drugs is the peak concentration, which is highlighted here in the Cmax. And we relate this Cmax, or peak concentration, relative to the MIC, which is sort of the delta between the Cmax and the MIC is represented with this arrow above the dotted MIC line. Classically, the types of antibiotics that demonstrate such concentration-dependent killing are aminoglycosides and fluoroquinolones. And really in the neonatal population, it's primarily aminoglycosides that we're giving to our babies. Things like gentamicin, amikacin, etc. Now again, the most common PD parameter that we care about with concentration-dependent drugs is the peak concentration to MIC ratio. And as you can see on the figure on the left, we see increased or bacterial killing as this ratio increases. So you can see that as the MIC ratio increases, you have increased bacterial killing, with highest killing in this line that's colored purple, which is 4 times MIC, compared to this line in the blue, which is only 1 times MIC. Now, to optimize bacterial killing for concentration-dependent drugs, the primary intervention is to increase the drug dose. Again, the higher the drug dose, the higher peak concentration that you're going to achieve, and the higher peak concentration to MIC ratio that you're going to achieve. However, we do have to be careful because with higher drug concentrations and higher peaks, we also run the risk of inducing toxicity. For example, the toxicities we worry about with gentamicin are things like oto and nephrotoxicity. And on a larger scale, on a population scale, we worry about inducing resistance when we administer sort of super therapeutic, unnecessarily high levels of aminoglycosides to kids when a lower dose would equally suffice. And then finally, there's this third sort of odd group that's a bit of a combination of the time-dependent and concentration-dependent drugs. And these are the time-dependent killing drugs that have prolonged post-antibiotic effect. The classic drugs that are in this group are things like vancomycin, clindamycin, and the macrolides. Now, the PD parameter that's best able to estimate the efficacy of these drugs is the area under the curve compared to the MIC. And on this figure, you can see that the area under the curve is this shadowed pink area, where basically this is the area under the curve where the drug is above MIC. You can optimize this AUC area by a variety of things. You can increase the dose, you can increase the duration of infusion. Now, I will also say that AUC to MIC ratios are not commonly used in neonates. Trough concentrations prior to the next dose are by far the most common manner of therapeutic drug monitoring in neonates, but the AUC to MIC ratio is certainly increasing in use in certainly in adults, where it's almost the standard now, and it's increasing in use also in pediatric patients. So now you may be asking, how do I use all of this sort of boring, physiologic, confusing data to actually help babies, to give them the right drug dose and to give them the safest drug dose? And this is through a sort of emerging science called pharmacometrics. And this is a quantitative science that incorporates pharmacokinetic and pharmacodynamic data analysis to inform drug dosing. This is primarily done through complicated statistical analysis that employs approaches like nonlinear mixed effects modeling. Compared to how it used to be done back in the day. So in the 70s and 80s, these pharmacokinetic studies would take 10 or 20 people, they would administer a dose of a drug, and they would get, 8 to 10 drug concentrations to really follow the trajectory of drug concentrations in that person over time. That is a less common approach now, particularly in neonates. And you can understand why that approach may be difficult in our babies. I shudder to think of how I could get any parent to consent for 8 to 10 phlebotomy encounters to follow such trajectories in a baby, because there's some significant feasibility and ethical concerns related to that sort of study in a neonate. And so, not just in neonates, but really in all patient populations, this population PK modeling has become more common. And this population monitoring can really sort of, as the name suggests, look at a population as a whole and parameterize based on variation in the population, which minimizes inter-individual variability and as a result, mitigate bias. As you can imagine, if you're doing a study on 10 to 20 people, you may not be completely reflective of the population. This population PK approach is really nice in the sense that it can accommodate sparse sampling, which means that you could get fewer samples for a given patient. And because you're going to combine all of this data as a population, you're going to, by nature, have drug concentrations obtained at different times. And even if you don't have all of the time points available for a single patient, when you combine the population together, you're going to have enough concentrations at varied time points among the population that it's not going to matter so much that you don't have, say, 8 to 10 concentrations per individual. And as this figure suggests, you might be able to get away with 3 to 4 concentrations per individual, which are going to be sort of compiled together to give a population estimate, which is shown in the panel on the bottom. This also accommodates missing data, as you can imagine. And then the other really important thing about population PK data is that it can incorporate developmental elements that are relevant to neonates. Traditional adult modeling often just scales based on something like body weight. And you can imagine that, scaling directly from an adult who weighs 75 kilos for, say, a parameter that's on elimination or liver function, scaling based on body weight to the neonatal population, where the body weight is somewhere between half kilo and 3 kilos, probably isn't going to give an accurate representation of the actual developmental elements that you're trying to reflect with this adult weight-based dose. And so there are neonatal specific functions that can really represent in a more physiologically appropriate way how things like elimination in enzyme activity are actually functioning in neonates relative to, instead of just saying, well, drug elimination in an adult works this way, so we're just going to miniaturize it. The PK modeling really can account for the fact that neonates are not just small adults, and really account for the physiological and developmental changes that are unique to this population. And a classic example of how this population PK modeling has tangibly affected neonatal care is the advent of extended interval neonatal gentamicin dosing. So as we all know, gentamicin is a renally excreted antibiotic, and there are toxicity concerns, particularly nephro and ototoxicity, related to giving this drug to neonates who have immature renal function and who are going to have delayed clearance. Initial dosing regimens from the 1970s frequently, extrapolated drug dosing from adults, and for that reason, gentamicin dosing every 8 to 12 hours was pretty common. There was a study in the early 80s by this gentleman, Dr. Mulhall, that looked at 91 neonates who were exposed to Q12 dosing. And what he found was that 60% of these babies had trough gentamicin levels that were really above the recommended threshold for redosing, which is 2 milligrams per ml. So what this means is that most of these kids given Q12 dosing weren't actually able to eliminate the drug to a safe level before the next dosing interval was due. And the worry with that is that if you're giving the next dose before the baby has appropriately eliminated the prior dose, that you may, over time, sort of get dose stacking and cumulatively higher drug exposure than you're aiming for, and inadvertently lead to some of these toxicity concerns related to increased cumulative drug exposure over time. And so over time, this hypothesis developed that, well, what if we just gave higher gentamicin doses at increased intervals? We think that this might allow us to achieve appropriate trough levels due to more time allowed to eliminate the drug. But because we're giving a higher concentration, we think we could also achieve higher peak levels. And so this has essentially been confirmed with multiple PK modeling studies. The figure on the left shows a study that compared 2 different dosing regimens. So this cross-hatched bars show a regimen that is babies that were given 4 milligrams per kilo of gentamicin every 24 hours. In the bars in black are showing babies who are given 5 milligrams per kilo every 36 hours. So the black is the extended interval dosing. And what this shows on the top half of the figure is that the babies who got the extended interval gentamicin in the black bars, a lower proportion of those babies had trough levels above the redosing threshold, meaning that those babies were better able to clear the drug prior to the next dose. And the bottom half of the figure shows peak concentrations. And what you see is that the extended interval dosing with a slightly higher dose certainly achieved similar or higher peak concentrations at all gestational ages compared to the classic sort of standard of care dosing regimen at that time. This has also been looked at in randomized controlled trials, which have not noted any increase in ototoxicity or nephrotoxicity associated with this extended interval dosing approach. And this has generally been implemented in most NICUs to my knowledge. Now we also have to think about antibiotic dosing in special circumstances. And this is where PK modeling can be very useful, knowing that there are even fewer babies who are exposed to these special circumstances, and that with modeling we can offer clinicians a bit of guidance of how to adjust drug dosing in these less common circumstances. So for example, neonates with cardiorespiratory failure who are on ECMO have many varied PK parameters. We know that they have increased volume of distribution and increased clearance, mostly related to being on the circuit, which is going to clear waste and drugs. But we also know that drug sequestration occurs via the circuit. For example, like a common drug that is sequestered is fentanyl because it tends to bind to the polymer in the plastic tubing. And so we know that PK is altered in babies on ECMO. And for that reason, therapeutic drug monitoring is really indicated for these babies for any antibiotics that they're administered. Another common scenario that alters pharmacokinetics is therapeutic hypothermia for babies who have hypoxic ischemic encephalopathy. So these babies have reduced clearance related to vasoconstriction that limits renal perfusion, in addition to any pre-existing asphyxia that they sustained in the process of their hypoxic insult. And so in these babies, it may be worthwhile to perform dose reduction for drugs like ampicillin, which are time dependent, or to further extend dosing intervals for drugs like gentamicin to allow adequate clearance. And so I'm going to go into a little bit of, like, with this context of what the barriers and opportunities for optimizing drug dosing in neonates are. So as I referenced earlier, there are very real technical and ethical challenges associated with obtaining these repeated phlebotomy samples from babies as required in traditional PK studies. And there's a variety of reasons for this. First of all, repeated sampling can lead to iatrogenic anemia. A vancomycin trough, for example, is like a half an ml. And when you think about the blood volume of a preterm baby who is 1 kilo, it's about 80 per kilo. Their total blood volume is 80 mLs. And so when you think about taking repeated half ml drug samples from a baby who only has 80 mLs of blood in their system, you can see how this could lead to iatrogenic anemia, which is something that we don't want to do for the purposes of research. The other very real point is that heel sticks are painful, and we know that painful insults have adverse neurodevelopmental impacts over time on our infants who are born preterm. And so for ethical reasons, avoiding painful procedures in these babies is something that we should be striving for. And for all of these reasons, from a sort of nuts and bolts perspective, if I'm a parent and someone's coming to me and saying, can I enroll your baby in this study where we're going to poke them a lot, they may need a blood transfusion and the pokes may be painful, you can imagine how many parents would not want to consent for such a study. And as a result, these sorts of studies just don't happen. And so we've had to think of ways to get around some of these barriers so that we can do studies in an ethically sound way that increases consent rates and allows us to include babies, particularly the smallest and most vulnerable ones for which the most data is lacking. I spoke a little bit earlier about sparse sampling studies, which are great because you can get fewer samples per patient compared to traditional PK studies. But the issue with sparse sampling is that you still need a higher sample size. And so, while a traditional PK study may need 20 patients, with sparse sampling, you may need 4 to 5 times as many patients, which is its own challenge in terms of study recruitment. But never fear, there are some innovative approaches that are being used in neonatal PK studies that are quite cool. One of these approaches is opportunistic scavenging, where basically you say, I'm just going to take advantage of samples that have been discarded, that were obtained for clinical use, and that the lab is otherwise going to throw away. That can include things like cord blood, which I'm using in some of my current studies, as well as residual clinical samples. So say the baby had a BMP that the lab has run and the blood is otherwise just going to be thrown away. Folks are taking that residual blood and storing it and saying, I'm going to use this later. And the benefit of that is that you don't have to poke the baby again. You're just sort of scavenging blood that's already in the lab and not letting it go to waste. The other way that opportunistic scavenging or sampling can be useful is to say, this doesn't mean that you can never do a prospective study. Certainly scavenging residual samples is a somewhat of a retrospective approach because you don't have control over the timing of those samples. However, you could do this in a prospective way just by coordinating your opportunistic sampling with clinically indicated blood draws. So in the NICU, a common scenario is that a baby needs glucose checks, and they may get a glucose check before every feed. And so you could realistically try to coordinate your study blood draw just with another clinically indicated sample, like a blood glucose, so that the baby's not getting additional sticks aside what they would otherwise be getting for routine clinical care. And then the other approach is to use these neat new devices that allow microsampling. So one of these devices is called a VAMS, or volumetric absorptive microsampling. And as you can see in the figure, these devices collect very small volumes of whole blood, and the analytic process related with these sampling can essentially extract the plasma or serum where the drug is residing and analyze it from a very small sample. That way you don't have to take half an ml of blood every time. You can take 0.2 mLs, which over time is a pretty significant cumulative reduction in the amount of blood that you're taking from the patient, which can reduce a lot of these anemia concerns. The next concern, again, is that neonatal physiology is varied. I mean, even among our population, a 22-weeker and a term baby are not the same baby. The physiology is radically different, and that development over time has to be accounted for. So as I mentioned previously, these common PK software packages often have neonatal components or neonatal sort of offshoots that you could theoretically do neonatal PK modeling on. But again, this software often scales directly from adults, and this can frequently lead to inaccurate assumptions, particularly when you're incorporating factors such as renal function or hepatic enzymatic function. And then finally, there's some sort of existential questions in neonates regarding to what should our targets even be when we're looking at PD targets for efficacy. Most of our pharmacodynamic targets, like many other things in neonatal medicine, are extrapolated from adults or older children. For example, for beta-lactams, which if you recall, the PD target that we think about is the percentage of time above MIC. Now, classically, in the NICU and with critically ill patients in general, most people, to be conservative, are going to want to target like 100% of time above MIC. However, there's data from adults, kids, even neonates that suggest for like penicillin that 40 to 50% of time above MIC may be adequate. The issue is that, there are no studies that are looking at this in neonates. I'm not sure that that's even a research priority, and for that reason, for neonates, we're not entirely sure what the T above MIC target should even be. And for that reason, we may be using more antibiotics than are strictly necessary. Another consideration here is vancomycin. Again, we commonly use trough levels in neonates, but I was shocked to learn that trough levels are not associated with efficacy or clinical outcome in neonates. Like, there are no studies that relate achievement of trough level of X with clinical improvement from infection or survival. On the other hand, these AUC to MIC targets, which have been established in adults of 400 to 600, are shown to have clinical and survival efficacy in adults. But when extrapolated into neonates, there is no data that relates these or validates these in neonatal populations. So we have a lot of sort of road to travel in terms of identifying even pharmacodynamic targets that are validated for the neonatal population, and that aren't simply relying on extrapolated values from adults. And finally, a very practical concern when we're thinking about doing studies to, measure pharmacodynamic targets or doing pharmacokinetic studies is the fact that clinical assays just don't exist for many drugs. I looked nationwide. I was trying to measure ampicillin levels, and I found about two laboratories in the entire country that had an ampicillin assay, and they were both commercial laboratories that cost a lot. Some of these assays are just not available to us in clinical care, and for that reason, no one does therapeutic drug monitoring because they have no way to do it. And unfortunately, developing these assays is really expensive, which further limits the types of studies that can be done on a clinical level to answer some of these questions. One thing we've done at my center is that we actually did develop a multiplex antibiotic assay with the goal to measure multiple antibiotics within one very small sample. We are able to measure multiple antibiotics in a sample of about 20 microliters, or about 0.2 mLs. We were able to achieve this by using high-performance liquid chromatography and mass spec technology, and we were able to combine multiple antibiotics used in the perinatal period in this assay, including penicillin, ampicillin, vancomycin, clindamycin, and gentamicin. This assay is great, right? We're able to, theoretically, we could measure 5 antibiotics in one 20 microliter sample that would otherwise require half an ml in a traditional laboratory to measure each sample. I will say that, developing this assay did require specialized expertise and equipment to validate. It was also really expensive. It cost us about $37,000 to develop this assay. And then the other thing that we learned in the course of developing this assay is that drug stability really varies, and this has implications on how you're going to do your PK study, and how you're going to collect your samples and store your samples. For example, ampicillin is really unstable at room air. It starts to degrade at room air within about 24 hours, meaning that traditional scavenging is less feasible for that drug. And so we've been having to do, going day of, to take cord blood as exposed to ampicillin to get it in the freezer within that 24-hour window. Other gaps in knowledge related to perinatal antimicrobial exposures are certainly there. We don't necessarily have great data that describes the magnitude and efficacy of fetal and neonatal exposures to maternally administered intrapartum antibiotics. This includes things like moms who get GBS prophylaxis in labor, or fetal exposure to antibiotics used to treat suspected intraamniotic infection. Our current clinical management of these babies exposed to intrapartum antibiotics has almost zero incorporation or integration of these intrapartum exposures in how we manage the baby postnatally. And the question is, should these exposures affect how we manage babies after birth? So I did a study to try and look at this. To just set the stage, intrapartum vancomycin is used as intrapartum antibiotic prophylaxis for group B strep among moms who have serious penicillin allergies. However, the transplacental transfer and efficacy of vancomycin for neonatal GBS disease prevention are unclear. And for this reason, the American Academy of Pediatrics defines vancomycin as, quote, inadequate GBS prophylaxis, where adequate GBS prophylaxis would include things like penicillin, ampicillin, and cefazolin. Now, why does this matter? This matters because early onset sepsis risk stratification tools, like the neonatal early onset sepsis calculator, essentially consider vancomycin exposed neonates to have received no GBS prophylaxis, and for that reason estimates these babies to be at higher early onset sepsis risk compared to neonates exposed to adequate GBS prophylaxis. Now, this is sort of hard to conceptualize in words, so I'm going to show you what this looks like in practice. So say that we have a baby here who's born at 40 and 5 weeks. Mom's highest temperature in labor was 99.4. She was ruptured for 17 hours, and she was GBS positive. Now, if this mom received adequate GBS prophylaxis, say mom got penicillin, the estimated early onset sepsis risk at birth for this baby is 0.24. This mom received vancomycin. The baby's estimated early onset sepsis risk at birth is 0.68. That's almost a threefold increase in early onset sepsis risk. Now, different institutions have different guidance on how this early onset sepsis risk is going to ultimately guide postnatal management and empiric antibiotic administration. But you can see here how just the factor of having received adequate GBS prophylaxis or not can have a significant impact on the baby's estimated early onset sepsis risk at birth, and how in many cases this could drive empiric antibiotic prescribing where it otherwise may not be necessary. Moving tax to gentamicin, again, this is commonly administered intrapartum due to concern for maternal intraamniotic infection, chorioamnionitis. So these newborns are exposed to intrapartum transplacentally acquired gentamicin. But we also know that intraamniotic infection is itself a risk factor for early onset sepsis. And so such neonates with early onset sepsis risk that's elevated might also get postnatal gentamicin. And they often give that immediately after birth because neonatologists like to get the antibiotics in ASAP. So you can imagine a scenario where a baby was exposed to intrapartum gentamicin 1 or 2 hours before birth. We assess them after birth as having higher early onset sepsis risk due to the fact that their mom had chorio, and we give them gentamicin immediately after birth. Our gentamicin dosing does not account for such intrapartum exposures. And you can imagine a scenario where this additional hit of gentamicin could potentially cause toxicity risk in these babies. Your second question may be, well, how the heck are vancomycin and gentamicin exposures related? Like, what do these antibiotics have to do with each other? And the answer is that they are related in terms of sort of how we manage these babies after birth. So, for example, babies who are exposed to vancomycin for GBS prophylaxis are considered to have inadequate or absent GBS prophylaxis with estimated early onset sepsis risk at birth. We know that increased early onset sepsis risk at birth drives postnatal antibiotic prescribing. And we know that ampicillin and gentamicin are by far the most common empiric antibiotics used to, quote, rule out early onset sepsis. So the objectives of this small study that we did were to quantify maternally administered intrapartum vancomycin and gentamicin concentrations in umbilical cord blood at birth. And secondarily, to identify the proportion of antibiotic-exposed infants who had antibiotic concentrations above clinical thresholds for efficacy and or safety. This was a retrospective cohort of babies born at my hospital, Pennsylvania Hospital, which is in Philadelphia, during calendar years 2022 and 2023. We opportunistically scavenged umbilical cord blood that we keep in a research biobank at minus 80 degrees Celsius. And we randomly selected cord blood samples that were exposed either to intrapartum vancomycin or to intrapartum gentamicin. Of note, maternal antibiotic dosing during the study period was as follows. Maternal vancomycin was dosed at 20 milligrams per kilo every 8 hours. And this does reflect a recent practice change from the American College of Obstetrics and Gynecologists. Previously, moms were dosed with vancomycin at 1 gram every 12 hours. And in 2019, such dosing was updated to recommend weight-based dosing to increase neonatal vancomycin exposure. Maternal gentamicin dosing was dosed at 5 milligrams per kilo every 24 hours. And we measured antibiotic concentrations via standard clinical laboratory assays. Our thresholds of interest, for vancomycin, we chose a threshold of 1 microgram per ml, which correlates to the GBS minimum inhibitory concentration. And for gentamicin, we chose a 2 microgram per ml threshold, which is the concentration, again, above which we typically would not immediately redose gentamicin due to increased risk of toxicity related to delayed elimination. We identified 26 samples exposed to vancomycin and 26 exposed to gentamicin, with most of these coming from term infants. We found that median cord blood vancomycin concentrations were 5.2 micrograms per ml, but the concentrations ranged from 0.4 to 14.8 micrograms per ml. Importantly, 24 of 26, or 92% of our cord blood samples exposed to intrapartum vancomycin had concentrations well above GBS MIC, or 1 microgram per ml. Yeah, Vidya, did you have a question? Okay. We also looked at gentamicin with median concentrations that were quite elevated at 3.6 micrograms per ml, with ranges of 0.2 to as high as 7.3 micrograms per ml, which is really quite high. 22 of 26, or 85% of our gentamicin concentrations were above our redosing threshold of 2 micrograms per ml. Skip this slide. Again, we found that there was significant variability and quite high levels of these intrapartum antibiotics in cord blood at birth, but we did have some limitations. We did not have concurrent maternal samples at delivery, so we couldn't estimate fetal placental transfer ratios. For vancomycin, we couldn't quantify the duration of fetal exposure to therapeutic vancomycin concentrations above GBS MIC because we only had single doses, so we couldn't really estimate an area under the curve, if you will, to estimate how long these babies might have been exposed to adequate GBS prophylaxis. And finally, our gentamicin thresholds focused on safety and timing of redosing, not whether therapeutic concentrations were reached. And it's certainly very possible that intrapartum gentamicin exposed babies might have needed a second dose of gentamicin after birth to achieve efficacy, but we weren't able to get at that based on our data. And so our conclusions from this were that there was substantial heterogeneity in cord blood, vanc, and gent concentrations following intrapartum exposures. Importantly, most of these antibiotic concentrations were well above clinical or safety thresholds. Classifying vancomycin as, quote, inadequate GBS intrapartum prophylaxis may estimate these babies' true neonatal early onset sepsis risk and could drive unnecessary postnatal neonatal antibiotic prescribing for rule-out sepsis. And modified gentamicin dosing at birth may be indicated in some infants with the potential to optimize neonatal safety and reduce early life cumulative antibiotic exposures. I see it's 8:40, and some folks have started to filter out, so I can stop here and answer any questions in case we're getting close to the time limit.
Dr. Coggins, thank you for this discussion. One of the questions I've always had is that infants born at a certain weight may have quite variable volumes of distribution, depending on their if they're IUGR or if they have increased volume retention. Does this nonlinear modeling make any compensation for this or give any insight into that?
Yeah, it absolutely can. And so that's why when we parameterize these models, you end up using multiple components. And so most of these models do end up using some combination of gestational age, body weight, and post-menstrual age to kind of get at the spectrum of growth restriction at a certain gestational age. And there have been some pharmacokinetic studies looking at particularly pharmacokinetics of drugs in growth-restricted infants. I can think of one study for sure looking at gentamicin with, I think, some signal for concern for, higher doses than we would recommend or anticipate for the SGA babies.
Yeah, because it's always struck me that, estimation of volume of distribution seems rather crude measurement, and it's used for trying to get very precise outcomes of dosing.
Absolutely. I'm not sure that there's any way to even do that in vitro. I think many of these early studies were done with some sort of like calorimetric or body composition testing. And so we are clinically, right, we're left with sort of our best guesstimate of body weight versus gestational age, and which is why, clinically when we get some of these really growth restricted babies, we have sometimes term babies who weigh 1,600 grams, right? And we have to say, well, we have all this guidance for what gentamicin should be dosed for a term baby, but should we actually go to the preterm dosing guidance and dose based on, what a baby would get based on birth weight for a 1,600 gram baby? I'm not sure that we have any specific guidance on what to do in that scenario, and I suppose I would probably inch towards dosing based on birth weight in that scenario. But you bring up a great point, which is that we don't have enough data to address that circumstance. And so I'll put the word out. Anyone that who's interested in pharmacokinetic studying in neonates, we need as many people who are interested as we can get, because it's going to require many centers to get enough babies to get the data that we need.
Okay, all right, thank you.
Yeah, thanks for the question.